Good morning, Rakshit. Rakshit, can you hear me? Sunil, good morning.
Good morning, sir. Chetan sir, good morning. Rakshit sir,
Good morning.
good morning.
Siddhant, are you on? Siddhant? Okay, fine, you're on. Okay. I think Shashidhara will join. He just give me a call. He's just joining.
Yes, holding on for Sanat.
Okay. Sanat should be there any moment. Rakshit, just check your presentation once. Rakshit. Rakshit, you need to unmute.
Yes, sir. How is the background looking, sir? Is it okay, or is that Karnataka Prosthodontic Society come in reverse?
No, it's correct. It's correct. Perfect.
It's correct, no? Okay.
Yeah.
Rakshit, it's looking good. Fine.
Then that's fine.
You must be a champion now in going on web. Doing so
No.
many. Hi, Shashi. Good morning, Shashi.
Good morning, sir.
Rakshit. Good morning, Sunil.
Good morning, sir.
Shashi, good morning.
Yeah,
Good morning. Good morning, Sunil.
Yeah, good morning.
Good morning, Rakshit sir.
Good morning, sir.
Camera is not on. Sunil, camera on agide alva?
It's on. It's on.
Fine, sir.
Yeah, it's fine.
Shashi,
It's fine.
Okay, okay. Yes, yes.
Shashi, ಎರಡು ಡಿವೈಸ್ ಇಂದ ಆಗಿದೆ ನೋಡು.
ಏನು login?
Yeah, that's fine.
I think
It's
they
okay.
have to give me permission to present my screen. They have to make me the admin or something like that.
Siddhant.
Sunil.
Siddhant? Yeah, I'm trying to press the. Yes, I did, but it's not the entire screen. Can you see now?
No, Rakshit.
Now we are on. Yeah.
I'm not able to see my screen.
It's you're presenting to everyone.
Yeah.
Is it fine now, Dr. Rakshit?
No, sir, it's not fine.
Sunil?
Siddhant, just look into it.
Yeah, Rakshit.
Siddhant.
Siddhant? Yeah, in the present now, I have to press on your entire screen, no? Yeah, but see. Okay, now if I exit from this and then I start my presentation, are you able to see the full screen?
Rakshit, you need to share my presentation. That's about
Yes,
it.
sir. That's not happening. Now?
Yeah. Rakshit Hegde is presenting.
Okay, now can you see the screen, sir?
Yeah, screen we can see, yes.
You can see the grafting in the aesthetic zone. Everything can be seen.
Yeah.
Now it's in full screen.
Now it's full screen.
Okay.
Morning, Rakshit.
Good morning, sir.
What's up?
Good morning, Sarath.
It's
Welcome
Sunday
back.
morning.
Hey, good morning. Ready, huh?
Ready.
Yes, sir.
Just waiting for it to be 10.
11.
Sorry, 11.
Chetubai, I can't see you.
Huh?
I can't see you.
Me. I am always invisible. It's always like catch me if you can. I'm not as visible as Sunil, you know.
No.
Sunil is the brightest.
Too much of light. 26.
Sanath, sir, are you at home or in college?
College, huh?
Huh?
Why on the Sunday college?
It looks like
The background
looks like a college.
I have college at home.
There is an almirah and one more bookshelf. So I think you have created a college atmosphere at home.
Yeah, very much.
Good.
Manoj sir, good morning.
I think he's having some issue with his instrument. He may not be able to reciprocate.
No, he's traveling.
Oh, he's on. Good morning. Sir has joined. Dr. Sridhar Shetty has joined. Sir, good morning, sir. Dr. Sridhar Shetty, sir. Good morning.
So good morning.
Good morning, sir.
Hi, Smita, it's you. Smita, good morning. Okay, we have Smita who's joined in. She's in a clinical attire. She's joined in from Muscat, if I'm not mistaken. Smita, you're in Muscat?
That's right, yes.
Wow. Smita is my classmate. She's a busy practitioner at Muscat. She's always interested in what's new. That's nice, Siddhant. Nice of you to join in. Thank you.
So much. Thank you so much.
Pleasure always.
Good morning, Chetan sir. Pradeep here.
Good morning. Hi,
Good morning,
how are you?
Pradeep.
Good morning, Manoj sir. Good morning, Rakshit.
Good morning.
Good morning, Pradeep.
Good morning, Sunil. Good morning, Shashidhar sir.
Good morning. Good morning.
Good morning, Sanat sir.
Good morning. Good morning, all.
Hi, Mridu. Nice you joined in. Long time. How is let me see. How is Chhattisgarh treating you?
Jharkhand. Sorry.
Jharkhand, sorry. It happens, you know.
Manoj sir, are you driving or just
He's driving, he's
Yes.
driving.
he himself is driving?
No, no.
Ah,
Somebody
good.
else is driving.
Too sincere.
Uh,
ಮನೋಜ್ ಎಲ್ಲಿಗಪ್ಪ ಚಿಕ್ಕಮಂಗ್ಳೂರು?
ನಾನೇನು ಹೆಬ್ರಿ ಹತ್ರ ಇದ್ದೇನೆ.
ಹಾ?
ಹೆಬ್ರಿ ಹತ್ರ ಇದ್ದೇನೆ.
ಹೆಬ್ರಿಯಾ? ಇನ್ನು ಸುನಿಲ್ ಚಿಕ್ಕಮಂಗ್ಳೂರು ಅಂತ ಹೇಳಿದ.
ಹೋಗ್ತಾ ಇದ್ದೇನೆ ಅಷ್ಟೇ. ಆನ್ ದಿ ವೇ.
ಸೀಮಾ ಇದ್ದಾಳ?
ಹಾ?
ಸೀಮಾ ಇದ್ದಾಳ?
ಹೌದು. ಅದೇ ಡ್ರೈವಿಂಗ್ ಆಗ್ತಾನೆ.
Hi, sir. Hi, sir.
ಹಾಯ್.
Hi, Nivya.
Hi, sir. Morning, sir.
Good morning. Good morning.
ಹೋಗ್ಬೇಕು. ಘಾಟ್.
Siddhant. Siddhant. YouTube link what you're given, the chat box is active, isn't it? Because some questions some might type few questions in the chat box in YouTube. So one of you have to make a note of it. Can you come again? Okay, you will link the questions here. That's what you meant to say.
Somebody who is handling the YouTube can type those questions in the Google Meet link.
Okay, that should be all right. So then just tell someone to either you tell them to pass on the question to me on my WhatsApp. That should be good enough. Sunil?
I think we can start.
Sunil,
Yes, sir. Yes, sir. We have about 65 already now. 70. Sorry.
we have 72.
Right.
Yeah. By
Yeah,
the time
we
you
are all in.
introduce.
Oh, yes. Yes,
Yeah,
yes.
sir.
We can start. Done it, sir?
Yeah, we can start.
Sunil, I think you can start.
Yeah. A very good morning to one and all. And it's an honor itself to gather here for today's webinar. This is one of the 8th webinar of the IPS Karnataka webinar series that has been going on. And we are very happy that it's been consistently going on every month, 2 webinars, and we are on with it in this COVID conditions. And I thank AB Shetty Institute of Dental Sciences, which has been organizing today's webinar on behalf of the IPS Karnataka State Branch. I would like to congratulate our IPS newly elected President, Dr. Akshay Bhargava, and I would like to welcome our Secretary, Dr. Rupesh, who is shortly joining in for this webinar. I would like to welcome one of our senior member and a founder member, Dr. Sridhar Shetty, sir, who is here, who is joined in today. Thank you very much, sir. And I would like to extend my warm welcome to our own president, Dr. Sanat Kumar Shetty, who is here, who has been very much instrumental and following up the webinar series. Thank you, sir. I would like to extend all the EC members, executive committee members of the IPS Karnataka State Branch for their active contribution support in all the programs. Apart from this, I would like to welcome all the delegates, all the postgraduate students who have been actively taking part in all the webinars. And I request all of you, if you have any particular things to have as a topic for webinars, kindly mail into ipskarnatakabranch@gmail.com. Apart from this, I am privileged to welcome our panelists for today. And I think we need no other introduction for Dr. Chetan Hegde sir, Dr. Chetan Hegde sir, who is one of the panelists. And sir is working as a professor and head in the AB Shetty Institute of Dental Sciences, which is one of the renowned colleges of our country. And he's been conducting a lot of courses, pre-conference courses as a national speaker. He's completed his PhD and many more. And sir has told me not to tell anything, but it's I'm just going it so brief that we all know, and I'm sure we all have learned many things from him. And our speaker himself is here to witness and tell that sir is as one of the panelists, and he should be really privileged to have him here and listen to him as the speaker. Thank you very much, Chetan sir. Our second panelist, Dr. H. S. Shashidhara. He is working as a professor in College of Dental Sciences, Davangere. He is a very active member of our IPS Karnataka State Branch. He is the executive member of our Karnataka State Branch, conducting many camps, programs, CD activities, and has many publications on his name. And thank you very much, Dr. Shashi, for having been accepted to be a panelist.
Thank you. Thank you.
And with this small introduction of this, I welcome once again all of you and real good participation. And we expect many more from all of you as we are having this webinars keeping on. So welcome one and all.
Thank you. Thank you, Dr. Sunil. Well, first and foremost, I would like to congratulate Indian Prosthodontic Society Karnataka State Branch for having received Best Branch Award from the head office. It's very nice to see the members from all over Karnataka not only coming together, but also contributing in taking the various activities of the branch and taking the branch forwards. It's very nice to see great bonding of members in conducting numerous activities like be it CD program, complete nature programs, or EC meetings, whatever it is. However, I take this opportunity to congratulate Dr. Sunil Dadade, who has over the years have done a great job as honorary secretary. Dr. Raghunath Patil as one of the earlier vice president, as one of the past presidents. Our own Dr. Manoj Shetty, Dr. Sanat Shetty, who have been instrumental, both of them, in taking the society forwards. I would like to add on Dr. Konark Patel, who is contributing immensely as a treasurer, looking after the GST matters. Dr. Umesh Pai, over the years, having done a great job as a editor of our, our journal. Yeah. Well, I would like also to thank all our senior members, Professor Dr. N. Sridhar Shetty, Dr. Ramanan Shetty, Dr. Ramesh Nadigar, Dr. Anil Bijari, over a period of time guiding us, the society in the right direction. I'd also like to remember late Dr. Satish Babu, who is instrumental in starting off this branch. Coming down to today's webinar. This is hosted by Department of Implantology, A.B. Shetty Memorial Institute of Dental Sciences. Implantology department at A.B. Shetty is a standalone department. It facilitates Department of Prosthodontics, Periodontics, as well as oral surgery in carrying out its implantology program for the postgraduate students. It also hosts a basic implantology course with 3 modules, and advanced implantology course, which includes direct sinus lift, sinus augmentation, full mouth rehabilitation, so on and so forth, having 5 modules. It also offers fellowship program of 1 year with 30 implants and numerous other activities. Anybody who has done BDS or MDS can join in for fellowship. People who are requiring more details into any one of the activities of Department of Implantology, please log into Nitya University website. Well, today I have proud privilege in presenting the Pride Piper of Department of Implantology, Dr. Rakshit Hegde, who will be speaking on grafting in aesthetic zone, when, what to graft. Now I request Dr. Shashidhara, Professor, CODS Davangere, to introduce and read out brief CV of curriculum vitae of Dr. Rakshit Hegde. Dr. Shashidhara, over to you. Dr. Shashi?
1 minute. Yeah, all of you can hear, I think, sir.
Yeah. Yes, please.
Good morning, everyone. I welcome all the participants to today's scientific session. First, I congratulate the past president, the president, secretary, and the EC members of Karnataka Prosthodontic Society for achieving the Best Branch in Oral Activities Award. And I wish to congratulate Dr. Sunil Dade for achieving the Best Secretary Award. So now I wish to introduce the eminent and renowned speaker, Dr. Rakshit Hegde. He is currently working as a professor at A.B. Shetty Memorial Institute of Dental Science, Mangalore. He pursued MDS in prosthodontics, including crown and bridge. He is accredited by DGOI, Germany, to conduct courses. He has completed diploma in Well Done, an alternative prosthetic protocol. He is a fellow and education delegate for ITI India section. He has attended many conferences of national and international repute. He is also a member of many research and academic societies. It is all in brief, that's all, to his credit actually. So, but in the last, I would like to request all the participants to post their questions or queries in the chat box, and it will be answered after the completion of this webinar. So I request Dr. Rakshit Hegde to go ahead.
Thank you, Dr. Shashidhar, for the introduction. Before I would start off with the presentation,
requesting all participants to be on mute during the entire presentation. Thank you.
Can everybody see the screen?
Yes,
Hello?
Rakshit.
Yeah. Go ahead.
The screen is on. Okay. Good morning, everyone. I would like to thank the Karnataka Prosthodontic Society for inviting me for this webinar lecture. Before I start off with the lecture, I would also like to thank the institution from which I passed out, because whatever I've learned, it's from this institution, great institution, that is A.B. Shetty Dental College, where I have graduated from. Well, along with the institution, of course, I have some mentors who have guided me throughout, who have been pillars of support at all time, especially Dr. Sridhar Shetty sir, who always pushed me to the next level because he wanted me to go ahead and do something different. So that did give me a push in the initial days. And of course, my other pillars of support were Dr. Chetan Hegde and Dr. Manoj Shetty sir. These two have been my professors and also my good friends at the same time, which has made me achieve what I'm today. So, of course, there are other people who have been contributed a lot towards my journey of success, what I would call it, to reach where I'm today. The topic today I'm going to speak on is something to do with grafting in the aesthetic zone. Why I chose this topic is because, we have taken these things very lightly, especially when it comes to the aesthetic zone replacement of teeth using implant-supported prosthesis, especially when it comes to grafting. We don't know when to graft and when not to graft. This is the institution where I'm working, that is A.B. Shetty. But before we go ahead and know about grafting, I think we need to go back to basics, that is about the anatomy. Anatomy of the maxilla and the mandible, especially in the aesthetic zone. We need to especially focus on the anterior maxilla, because it is this area which is the most visible when the patient is going to smile, especially for a patient who's got a very high smile, wherein the papilla or the mucosa is completely visible when the patient smiles. Aesthetics becomes a very important criteria for this patient, and especially replacing a tooth with an implant, you need to take care of certain biologic principles to get a good outcome. So what are we dealing with here in the anterior zone? We're dealing with especially when it comes to extraction and immediate placements, we deal with very thin sockets in the anterior region, very thin plate in the anterior region, that is a buccal cortical plate in the anterior region. So what happens is when an extraction is done, there is a physiologic remodeling of the buccal cortical plate which is there. So this physiologic remodeling of the buccal cortical plate will cause loss of contour of the buccal cortical plate. So along with this, we also have certain areas, that is the incisive fossa region. Okay, this is where we need to also look into, because if we had to go in with the same direction in which the tooth was earlier present, going apical to the root tip where the tooth was present, then what's going to happen is the implant is going to perforate on the buccal cortical plate or the labial cortical plate, and then have a perforation on the buccal aspect. So we need to look at these areas very carefully, that is the incisive foramen region especially. And on an X-ray, especially on an OPG, we usually take a OPG before we, for screening purpose, before we start off with an implant placement. So what do we see here is, especially in the area where incisive fossa is there, we would see a darkened area. Okay, we might think that this is cyst or some kind of pathology which is there in that particular area. But the best way to diagnose is go ahead and take a periapical radiography. So when you take a periapical radiography, you don't see a zone which has got a lesion kind of a radiographic picture. So we need to take intraoral periapical radiography to distinguish between a lesion and a good bone. So that usually happens in the incisive fossa region. This is also seen near the canine fossa. If you had to ask me which is the worst area to place an implant after immediate extraction placement, I think it's the canine region, because it's the canine region wherein you see the buccal cortical plate, which is really thin in that particular region. And you see a lot of resorption happening in the canine region when compared to any other area. Though, we always think that canine has got good bone. If you had to actually see, you will end up seeing that the canine region, you have very minimal bone if you had to do an immediate extraction and placement, especially for those conditions. Because I'm talking more about immediate extraction placement. The reason being, patients are more and more focused of getting a tooth replaced at the same time. And we as prosthodontists and implantologists are compelled to go ahead and place the implant at the same time and then restore it to the normal occlusion and normal contour most of the time to get good aesthetics also. So that's the reason I'm stressing more and more on immediate extraction and placement, because these are situations where you need to think whether you need to graft or not, or where to place your implant. If you had to look at other anatomical landmarks in the anterior region, the other anatomical landmarks, what we need to look at is the nasal floor. Try and avoid perforating the nasal floor. A lot of people, we have a small group of people who are moving towards basal implantology. Well, basal implantology is something wherein they believe in perforating the nasal floor. This is not right to do it. The reason is, there is a chance of infection when you perforate the nasal floor. And also, there is a discomfort to the patient at times. I wouldn't say always, but, there are discomfort to the patient at times. So, you need to see to it that you don't perforate the nasal floor as long as possible. You can engage the cortical bone of at the nasal floor region, but that doesn't mean that you perforate the nasal floor area. But also what we could use the nasal floor area is especially the spine. You have the nasal spine, which is here. So when you're placing an implant in the aesthetic zone, all you need to do is slightly reflect more, look into the area where the spine is present, and then you could use some autogenous chips from those areas so that you don't have to open up another surgical site. It's good to use some amount of autogenous chips along with other biomaterials. It's not good to either use entirely autogenous block bone or entirely use a substitute, bone substitute, because we need to look at integrating biologically with the implant. That is, the implant needs to integrate well, and also the osseointegration needs to be much faster in the area where the implant is present. That is, where the implant is coming in contact with the bone. So whenever we want to do a contour augmentation, it's best to augment on the surface of the implant with the autogenous chips, and then contour on top of it by using a xenograft material. So this is the way to go ahead and then do the grafting. Because when you do this particular method of contour augmentation, you're going to end up with good vital bone around the implant, and the contour which is there around it being maintained for aesthetic reasons. Okay, so we need to try and look at aesthetics and also look at function when we are trying to do an augmentation. Also, in the anterior zone, especially when you're doing an implant placement in the central incisor, we need to look at the nasopalatine canal for different reasons. Nasopalatine canal by itself comes in different sizes in different people. So there are some people in some conditions where you see the nasopalatine canal exactly where the central incisor is present. So implant placement becomes very difficult in these particular clinical scenarios. So you need to try and avoid damaging the nasopalatine canal. At the same time, if you look at the contour which is there here, not much of a contour augmentation can be done here. Your implant needs to come in the right three-dimensional position. You can't move the implant buccally and place the implant buccally just because the nasopalatine canal is very large in that particular region. Because if you try and do this, what's going to happen over a period of time is there's going to be exposure of implant on the buccal area, and that's going to cause a gray issue on the buccal cortical region. So please do not try and place your implants on the buccal aspect, but it has to be in the three-dimensionally perfect position. A lot of articles regarding the abnormal sensations which can be there with the damage of the nasopalatine canal, which is there. So you could go through these articles, especially the article by Urban et al. Okay, is the one Urban has written a very good article in that in 2015. So you could go through that. What goes through the nasopalatine canal is the neurovascular bundle, nasopalatine duct, and omoronasal organ. So these are the things which goes into the nasopalatine canal. Well, extraction and immediate placement. Well, in earlier days, we just believed with osseointegration. That is, when implants were introduced into dentistry, they looked at more of osseointegration, and it was believed that if an implant had to osseointegrate, that's called success. But this is not success in today's date. In today's date, success has got something to do with more with function, aesthetics, and along with that, osseointegration, and also the pink and white aesthetics along with it. You can't have success without having a good pink and white aesthetic. So we need to try and achieve a good pink and white aesthetics if you have to look into success in today's implant dentistry. So to understand this, what we need to understand is also what happens after extraction. So if you have to go by the articles of Araujo, you would see that after extraction, especially after 8 weeks after extraction, there is a large amount of bone loss, especially happening on the buccal cortical plate, whether it's an anterior or the posterior region. This is what we usually see in after extraction. So we need to try and avoid an immediate implant placement just without doing any augmentation, because if you had to try and place an implant without doing an augmentation, especially in cases where there is thin biotype, what you would usually see is there is a big loss of buccal cortical plate, which is there. The facial bone loss is close to about 2.6 millimeters. So if I had to, that is after 12 weeks of time. So 12 weeks is the time when you would go back and load the implant. So it is that time when you would see that there is a lot of bone loss which has taken place on the buccal cortical plate, especially with a thin biotype kind of a situation. Immediate implant with GBR at the same time, the bone loss is comparatively less when compared to not doing an augmentation. So it's best to do an augmentation at the time of implant placement to prevent bone loss. Well, there is another alternative. If you don't want to do immediate implant placement and then go ahead and then wait and then place the implant, then what you could do is, you could go ahead and do something called as socket grafting and wait for 6 months and then go ahead and then place the implant. So what is the amount of bone loss which is taking place with the socket grafting? It is close to about 12% of bone reduction, which is there with socket grafting, which is there after about 6 months of time. But what graft to use is a questionable thing. What graft to use, I would say, use a xenograft material if you want to preserve the bone for good 6 to 12 months of time. Suppose you have a patient walking into your clinic and then the patient needs to place an implant, might be after about 6 months or a year, because the patient is traveling out somewhere and the patient is going to come back after a year, which we usually see with the NRI patients. So, you need to try and preserve the ridge for these kind of patients. So what we do is, we could go ahead and do socket grafting for these kind of patients and then wait for 6 months or a year's time. But there would be about 12% reduction in bone volume which is there. So what you could do is you could graft slightly more than what is required. So what you would do is, might be graft about 20% more than what's required. So do a contour augmentation and effect of the cortical plate also along with socket augmentation if the patient is coming back after 6 months to a year's time. Well, 6 months is not something which is standard for all the sockets. 6 months is a standard protocol to follow if you are grafting in the molar region. So if I had to graft in the anterior region, I could wait for 3 to 4 months of time and then go ahead and place the implant, because the socket is much more smaller in size when compared to the socket which is there in the molar region. So we could alter alter the time depending on the area where you're doing the grafting. But 4 months is the minimum time that you need to wait in case you're using a xenograft material. In case you're using something like an allograft material, if you're using an allograft material, you need to use the cortical allograft material. Okay, so you get the different types of allograft material, but what you need to use is a cortical allograft material, because the cortical allograft doesn't resorb that fast. So use the cortical allograft material, and then you could come back and place your implant in 3 months' time also, because the allograft resolves faster and also regenerates faster when compared to the xenograft material. So you need to try and understand what kind of graft to use in that particular clinical situation, and what is the patient's expectation, and when is the patient wanting to place the implant, or how long can the patient wait. This is what we need to try and understand. If you had to go by the article of Vivian Chaplus, what you would see is that there is a good progressive bone loss which is taking place, especially in this area where the buccal cortical plate is present, where the thin facial bone is present. So in a case where the buccal cortical plate is very thin, you would see close to about 7.5 millimeters of bone loss taking place on the buccal cortical plate. This is the CBCT images which has been overlapped with the immediate, after extraction, a CBCT was made, and then the CBCT was overlapped after 3 to 6 months of time, and then this is what we usually see. You don't have to really wait for 6 months to see this kind of a bone loss, or you would immediately start seeing in about 6 to 8 weeks of time this kind of a progressive bone loss which is there in a buccal cortical plate which is very thin. Whereas if the buccal cortical plate is thick, you really don't have to worry, because there's minimal bone loss taking place when the buccal cortical plate is thin. So you need to understand where is the risk zone, the central area of the extraction socket, wherever it is, that is the riskiest area. So you need to look at these two kind of phenotypes which are there. Well, the gingival phenotype, whether it's a thin or a thick, I think all of you know about it. In the same way, you have the critical bone wall thickness also, which is correlating with the phenotype which is present. That is, the thin phenotype usually coincides with the thin buccal wall, and the thick phenotype usually coincides with the thick buccal wall. This is usually correlating. But if you had to look at in the anterior region, I would say 90% of the cases that we handle fall in the thin wall phenotype kind of a situation. So I hope all of you understand that we are dealing, whenever we are dealing with the anterior region, we are usually dealing with a thin wall phenotype kind of a situation, where we might see the buccal cortical plate after extraction. That is, if you had to try and feel it with any instrument, probe, you would always feel that there is a buccal cortical plate. But how thick is the buccal cortical plate is important to know, and the only way to know is to take a CBCT. So always when you are doing an immediate extraction placement, I would advise to go ahead and make a CBCT for all your anterior cases before you decide whether to graft or not to graft. So you could do your bone loss analysis, okay? So in a thick phenotype kind of a situation, what do we see here? The buccal cortical plate is still intact, okay? So this is in about 90% of the cases where you have more than 1 millimeter of buccal cortical plate being thick. 1 millimeter thickness, more than 1 millimeter thickness is only in 90% of the cases. And the best is when there is about 2 millimeters of thickness of the buccal cortical plate. You really don't have to worry when there is about 2 millimeter of buccal cortical plate thickness, but it falls in a category which is just 6.5%. Okay, so if you want to go through the article, Nivens has published an article in 2006, and then of course, subsequently, there were a lot of other people who did come up with a lot of articles supporting Nivens' article. Well, looking at the thin wall buccal cortical plate, when you do a CBCT, this is how a thin wall buccal cortical plate looks like immediately after extraction. Okay, so you could see here a thin wall buccal cortical plate which is there. If I had to use a probe and check, you will always see this. And this is in the canine region. Mostly you would see this kind of a clinical scenario. The tip of the canine is usually coming out of the buccal cortical region. Usually, if you had to use your finger and then go ahead and try to palpate in the canine region, you'll always see that the root tip is usually outside the buccal cortical plate area. Okay, so try and not place your implant exactly straight into this area, but you need to place it on the palatal wall, but also at the same time maintaining the same long axis of the natural teeth which is there. So what do we see here? With a thin buccal wall which is there, you would see a bone loss which is compromising the buccal cortical plate. Earlier, the buccal cortical plate was somewhere here. You can see here the buccal, there's a thin buccal cortical plate which is there here. So if I had to place my implant in this area, what would have happened is my 2/3 of the implant would be exposed on the buccal area, thinking that the bone is going to form in this area. So please do not do this when you see a thin buccal cortical area. A study done by Vivian Chaplin, what she did was she made impressions before extractions, 4-week extractions, 6 weeks, and 8 weeks. So, and then compared these models over each other by superimposing the model. So when they superimposed the models, there was a defect seen on the central area, that is where the tooth was extracted. In the center, there was a defect which was seen because there was bone loss, and at the same time, there was loss of facial profile which was there at the end of 8 weeks of time. So this is just by comparing it with the models before extraction, after extraction, and then at 8 weeks of 2 weeks, 4 weeks, 6 weeks, and 8 weeks of time. This is how she compared. And then found out that this is what we lose on the buccal aspect. So thin bone type, you lose about lot of buccal cortical plate, whereas on a thick bone phenotype, you hardly lose anything. Now, let's look at what is the soft tissue thickness which would change. Along with the hard tissue, we need to also look at soft tissue. As I told you, it's soft tissue would stay at the right position only if it's being supported by the hard tissue. So we need to try and understand where the soft tissue would be and what is the thickness of the soft tissue which is there. At extraction, usually we call when a study was done, they saw that with thin phenotype kind of a situation, an average of 0.7 millimeters was present, and thick phenotype, this was the average thickness of the phenotype which was there at 0.8 millimeters. But 8 weeks after extraction, what happened to this thin phenotype? There was a resorption of the buccal cortical plate which was there. The socket was present here, and since the socket was present there, during the regeneration of the soft and hard tissue, initially the epithelium migrated into the socket and then formed a soft tissue which was as thick as 5.3 millimeters after 8 weeks of time. So the soft tissue filled up into the socket region here. Okay, and in a thick phenotype, the soft tissue reduced from 0.78 to 0.7 millimeters. Okay, again in the same article, she has described it. So you could go through that article of Vivian Chaplin. Okay, so why does this happen? This happens because, see, now the buccal cortical plate is thin down here, and then the soft tissue forms here in this particular region here. That is after 8 weeks of time, this is what happens. Okay, so here in the thick phenotype, you have the bone forming in the apical area. There is not much of a bone which is formed here in this area, but you could see the bone forming in this area in the apical region at 8 weeks of time, though, you know, it's very soft bone which will be there if you had to go and do an osteotomy, which is perfect to go ahead and do it as an early placing protocol, which I like doing because you are going to eliminate the question of risk when you wait for about 6 to 8 weeks of time. In case there is a periapical pathology, in a question of 6 to 8 weeks of time, this periapical pathology is going to resolve, and then the success of the implants would be much higher when you do an immediate extraction and placement. Well, immediate extraction placement, you need to try and do a good curettage and be very sure that there is no periapical pathology when you're doing an immediate extraction placement. But if you are a beginner, I would always advise you to go ahead with early placement, that is in 6 to 8 weeks of time, come back and then do the placement, because then you're very sure that there is no periapical pathology, there is some amount of bone which is formed in this region, and you could place the implant. And also a safe bet when you're looking at the thin phenotype kind of a situation, because you're very sure that there is a bone which is lost here, and then you need to do an augmentation. So this is what happens. 50% of the bone resorbs within 2 weeks of time. This is what was seen. 50% of the bone, whatever is going to resorbs in the first 2 weeks of time. So what we need to also see is what happens with the contour. Okay, if you have to go by the article of Danny Boozer on the concept of early implant placement with simultaneous augmentation and GBR, you would understand why you need to place the implant at 6 to 8 weeks of time and not immediately in most of the clinical scenarios, especially in the anterior region. So if you look at the anterior region, the soft and hard tissue alterations, actually in a thin phenotype kind of a situation, you don't see a lot of alteration when compared to the alteration which is taking place with the bone alteration which is there. The bone, there would be close to about 7 to 8 millimeters of bone loss at the buccal aspect, but on the, if you have to look at the soft tissue alteration, there is hardly any alteration. This is a typical case, what I would like to show you. Done in our institution. You see this after 6 to 8 weeks. This is what the buccal contour is there. Okay, so there is a good amount of ridge width, what you see here, but actually this is just the soft tissue which is there here. So in such a clinical scenario, what you need to do is please place your incision slightly on the palatal region, somewhere here. You have the cingulum of the adjacent teeth, cingulum here. So go in this area, because it is in this area where you would see the palatal plate which is there. So on the area where the palatal plate is there, you need to place the incision. Okay, so and then go ahead and do the implant placement. But before you go ahead and do all these things, I would suggest that all of you could go through the SAC classification tool. The SAC classification tool is a very good tool to use, especially if you are doing an implant practice, whether you are a student or a practitioner. Practitioner who's been practicing for a long time also, I would still advise to go in with the SAC classification tool, because it will help you in knowing what is the treatment outcome. It would also tell you whether an augmentation is required or not for this particular clinical scenario. So if I had to go in with the SAC classification tool, this is the result which has come for this particular case which is there. I put the patient name as for KPS, ID, and today's date is there here. So what do we see here? When we look at the placement protocol for this particular patient, it's an early or a late implant placement protocol which is there. Bone volume deficient horizontally, and which is allowing for simultaneous augmentation, because we are looking at simultaneous augmentation. What is the anatomic risk? Anatomic risk is quite low in this particular case. Aesthetic risk is high because it's in the anterior region, and also the smile is high. So the aesthetic risk becomes high here. The risk of complication is low because you're doing a staged procedure here. That is after a healing period of 6 to 8 months of time, the complications are usually low. Okay, and additional procedure what is required is a simultaneous horizontal bone augmentation. Might be a adjunctive soft tissue graft, might be, okay, this might be required. Additional risks, what you can see is, if you don't perform the soft tissue surgery good enough, you could see a gingival recession on the adjacent side, involvement of the metal nerve, which is in case it's lower anterior. Well, it's not in this particular situation. There can be complications in the grafted side. And since the patient expectations are high in the anterior region, the risk is higher because, losing aesthetics in the anterior region makes your treatment compromised. Okay, so this is what we need to try and understand. For this patient, the medical condition is healthy. Smoking habit, the patient smokes less than 10 cigarettes a day, which is okay. I mean, it still does not come in the high risk category. The high risk category is when the patient smokes more than 10 cigarettes, it comes in a high risk category. Best is the patient does not smoke. But if the patient is smoking less than 4 cigarettes, I think it's as good as the patient is not smoking. So, you could go ahead and do the implant placement. But if the patient is smoking less than 10 cigarettes a day, the patient still comes under the medium risk category. It's not low risk, but it comes under the medium risk category. So this is what we need to try and understand. There is exposure of the papilla. So the lip line is visible and there is exposure of the papilla. So you have medium risk. Gingival biotop is medium. So it's in a medium risk category. The rest of the things are fine. So, this is what we could give it to the patient also and make the patient sign this along with the consent form. So the patient exactly knows what is the treatment outcome and whether it's an advanced treatment or whether the treatment is a regular straightforward treatment. So this becomes an advanced treatment because you're grafting at the same time, though it's not complex. So you have a simple, straightforward, advanced, and complex treatment protocols, which are there with the guidelines, which are there with the SAC tool. So please use the SAC tool for classifying in these particular clinical scenarios or any clinical scenario that you work with. So you see here, the incision is palatally placed. If you had to look at my BP blade, it's completely in. Why it's gone completely in is because there is no bone which is found on the in the socket region. And when you open the flap, what do we see here? There is no buccal cortical plate which is there here. Absolutely no buccal cortical plate. The implant is present here, but there's no buccal cortical plate. But what you also need to appreciate is the soft tissue which is there here. This is the beautiful soft tissue which is there here, which is helping you in yes. Yeah, this is the soft tissue which is there here on the buccal aspect along with the flap. So this is the soft tissue which is very good to have because you have changed a thin biotype into a thick biotype kind of clinical scenario. I showed you earlier, it goes up to 5.5 millimeters of thickness of the soft tissue in the area where you have done the extraction and waited for just about 6 to 8 weeks of time. So you need not open up another site to do a connective tissue graft. So as a prosthodontist, we always like to keep our things very simple. So a very simple way to do a soft tissue regeneration is just to wait for about 6 to 8 weeks and then go ahead and open the flap by going with the incision on the palatal aspect. So you see the soft tissue which is there here, which is going to increase the thickness of the convert the thin biotype into a thick biotype kind of clinical scenario. Place the graft and the membrane. You could use the graft and the membrane of your choice. If I'm using an allograft material, I would use the cortical type of allograft material and use a double layer membrane. Always use 2 layers of membrane. This is what we need to try use. A collagen membrane is what we need to try and use. You need to place a horizontal mattress suture initially, which will stabilize the membrane, and also it would close the flap at the same time. And then you have the interrupted sutures, which will help you in closing the flaps on the crestal area. But initially, you need to place a horizontal mattress suture. The suture material to use would be a PTFE suture material, if possible, because PTFE suture material does not resorb and does not lose its tension over a period of time. Because you need to use this horizontal mattress suture deep end, that is 5 millimeter below the area where you put the incision. You need to put in use the suture that is for horizontal mattress, and then suture 5 millimeters above the incision line, so that the tension is all taken up by the suture which is there and not by the area where the flap is closing. So then you could close the flap on the area where you put the incision. So what do we conclude from this? the first conclusion is in thin phenotype kind of a situation, you have, when you have more than 1.1 millimeter, there's hardly any alteration taking place. There is just about 10.5% of alteration which is there. But in a thin phenotype, there's close to about 62.3% of alteration which is there. But at the same time, we need to understand the positive side of the thin bone phenotype. That is, in a thin bone phenotype, it's best to wait for about 6 to 8 weeks and then go ahead and then do the augmentation, because then you have a thicker soft tissue for regenerative procedure. And also, this would mask the true bone defect which is there. Okay, so these are the things what you need to understand with a thin phenotype kind of situation. Well, flapless extraction preserves more bone in early healing phase is another conclusion to take home. Okay, and what we need to also understand is, can you influence the bone remodeling by socket grafting? I did speak about the socket grafting. Well, yes, you can influence the bone remodeling by socket grafting. So it's best if the patient is going to come back after a long period of time, then go in with socket grafting, because there is hardly any alterations with the ridge, width, and height which is taking place when you do a socket grafting. So try and do a socket grafting whenever required, but not always. What we need to what we cannot avoid is the bundle bone resorption by socket grafting. So that's why I told you, you know, when in a thin phenotype kind of a situation, open the flap and then also augment, not just in the socket, but also on the buccal aspect. And what is the size of the graft material that you need to use? You need to use something like the small particle size, 0.25 to 1 millimeter particle size of graft material. And you're doing the socket grafting and also on the buccal contour of the buccal cortical plate. So you need to try and preserve this bundle bone also. So what will happen is when you augment, it's more like a sandwich technique where you have grafted inside the socket, grafted outside the socket, and then you are trying to preserve the bundle bone which is there in between. So what happens is when the bundle bone is resorbing, there is still a contour which is maintaining on the buccal aspect of the bundle bone which was present, and also on the socket region, and then the bone again forms back in these particular clinical situations. So this is what you could try and do for your clinical cases in case you're waiting to do a socket grafting and preserve the bone for a long period of time, because the patient is coming back after a year. Okay, so we need to understand these things. When is socket grafting indicated? If it's indicated usually when the early implant is not possible, or if there are any medical conditions, or if there is a big defect which is there in this kind of a clinical scenario, you could go ahead and then do the socket grafting. We need to understand certain things, you know, other than these principles, whatever I was talking about. We need to understand that as a clinician, our clinical skill and the education what we have, and also the experience plays a big part in utilization of the graft and also the treatment approach for the patient that you're treating. So we need to understand all these things before we go ahead and do the treatment. Again, going by the SAC tool, if you had to analyze what is the kind of risk or difficulty that you're facing, you have a list of things which are there. So you could go by the ITI volume, which is the 2009 volume, and then you would get all these things. So here, what you need to understand is, you know, the aesthetic risk. Okay, this is what we are trying to focus today, the aesthetic risk. Whether there's an aesthetic risk, if it's no when the bone type, biotype is thick, and also the facial wall is more than 1 millimeter. But at the same time, the aesthetic risk is high if the biotype is thin and insufficient bone thickness is there, that is less than 1 millimeter. So in the anterior region, try and understand this always. Okay, so if you understand these basic things, I think we can't go wrong. So if you go by the article of bone stain, you would see that how the CBCT images have been made, and then in which particular clinical scenario you need to be very careful, especially when it comes to the different types of teeth which are there. Okay, a very ideal placement would be, you know, when you have a tooth which is straight within the socket, not coming buccally like in the first picture here. Okay, in such a clinical scenario, when you see a CBCT, something like this, then you could just go ahead and place the implant. But in this case, what you see here is the buccal cortical plate is just about 0.5 millimeters. So when the buccal cortical plate is 0.5 millimeters, you need to try and augment in this particular clinical scenario. In this particular clinical scenario, there is the last image, what you see here. The buccal cortical plate thickness is about 1.46 millimeters, a very good clinical scenario. Do I need to graft in this clinical scenario? I would say no, not really required to graft in this clinical scenario. You could place an implant, might be place a gingival former if you're not loading it, or make a prosthesis which will help in supporting the soft tissue profile on the buccal aspect. And this soft tissue profile would remain intact, and also there wouldn't be any bone formation in the area where, or in between the buccal cortical plate and the implant which is there. Don't place a very wide implant. At the same time, see to it that you maintain the jumping distance less than 2 millimeters. So don't keep it more than 2 millimeters. And if it's more than 2 millimeters, you need to put some graft material. Do you have to put graft material into the entire socket? I would say no. You need to just put it at the cervical region, at the area where the collar of the implant is coming. Only there you need to put the graft material, and just leave it over there. And in the apical area, the blood would fill in and the bone would form on its own. In fact, this is a very good thing to do. When you do a socket grafting also, if the patient is going to come back after about 6 months or a year's time, but these kind of a patient, I would say, just put even a non-resorbable membrane, might be okay, something like a perma-mem is what you could use just on the socket area, and then you could just leave it there, and then the bone will form inside without putting a graft material also. But you need to put a non-resorbable membrane, okay, which requires a second stage surgery. But you know what I would advise is go in with a resorbable membrane, something like a collagen membrane, because you don't have to open up completely when you're doing the implant placement. Because the moment you start opening the big flaps, what's going to happen is you're going to start seeing bone resorption. So try and not open up a big flap whenever you're doing an implant placement, unless it's absolutely required. Okay, you need to open minimal, because the moment you open bigger flaps, you're going to disturb the periosteal blood supply. The moment you disturb the periosteal blood supply, then you start seeing bone loss taking place. If there is bone, you're going to have good aesthetics, because the papilla is going to maintain well when there is good bone which is there. So again, the same conclusion with the bone stain study. More than 90% of the teeth had got a thin facial bone wall at the crestal level. So, we need to try and augment in this region. So which are the most, the bone wall thickness in the crestal region, which has got the highest bone wall thickness in the crestal region? It is usually the premolar area, which has got the highest bone wall thickness in the buccal bone wall thickness, which is there in the anterior region. Okay, the premolar area might be in the first premolar region. In fact, a premolar also falls in the aesthetic zone. We can't consider the premolar as a posterior teeth and then exclude it from the aesthetic zone. Well, the premolar also comes in the aesthetic zone. So in these kind of a clinical scenario where the bone is more than 1 millimeter, then you could go ahead without doing an augmentation procedure. So you close to about 28% of cases you would see the bone which is thicker in the first premolar region. So we need to understand something that is about horizontal bone augmentation. 3-wall defect and 2-wall defects. This is what we commonly see. Well, the 1-wall defect is usually in completely edentulous patients. So the 3-wall or a 2-wall defect is what we commonly see. So what is it that we need to understand here? These are post-extraction cases, might be for immediate implant placement. Possibly flapless placement is what we need to understand in a 3-wall defect, what we could go ahead and do. Internal grafting might be with allograft or xenograft, and might be an immediate restoration is what we could do in a 3-wall defect. In a 2-wall defect, mostly in post-extraction or early implant placement, you could go ahead and do the implant placement. The case what I showed is more of a 2-wall defect where the early implant placement, the collagen membranes are required, but no fixation is required. You could do the fixation by using just the horizontal mattress suture. You don't have to go in and use some titanium tacks to do the fixation of the collagen membrane. You could use the autografts or the xenografts for primary closure. So what are the options which is there post-extraction? Immediate implant placement is on the same day, which we do. An early placement is usually after about 4 to 8 weeks of time with soft tissue healing. This is what we need to try and concentrate for good long-term achieving of aesthetic and functional success. I think an early placement is the best protocol to follow rather than going in with the immediate placement, because an immediate placement needs to have enough skill of the person doing the implant placement. So only if the clinician is skilled enough, then I think you need to go in with the immediate placement. Otherwise, the best protocol to follow would be an early placement where there is just enough soft tissue healing. Of course, you could also do it with partial bone healing in 3 to 4 months of time, and late placement with complete bone healing is after 6 months of time. Well, of course, there is very good bone formation at the end of 6 months. I won't go more into this SAC tool here. Let me show you a case wherein a canine is extracted and implant is placed here. If you have to look here, where is the canine which is there? If you have to take the cross section, this is the most dangerous thing. If I had to think, I'm going to place the implant right where the canine was present, and my implant is going to come on the buccal aspect. You're going to have a perforation here. So you need to analyze this by doing a CBCT. Always analyze by doing the CBCT, and then you would exactly know how much of bone is present. So what we need to analyze is what is the amount of risk which is there, whether the case is an advanced case or a complex case. Complex case where there is a big defect, both hard and soft tissue defect, then you need to go in with augmentation, wait for about 4 to 6 months of time, and then go ahead and place the implant. Whereas this was a case which is with a moderate complication, that is an advanced case, where you see that the buccal cortical plate is completely missing in this region. You could place the implant in the right position, then augment by using a graft material. In this particular case, we used Bio-Os collagen as a graft material, which is a combination of a bovine and a porcine material. It's 90% bovine and 10% porcine. 90% bovine and 10% porcine. The handling of this particular material is very good, and it just stays in position very well, and you could nicely contour augment the material. What you see here is small scrapings of the autogenous chips, which is there here. So I would use this small scrapings of the autogenous chips on the surface of the implant, and then augment the rest with the graft material. And then, of course, membrane, collagen membrane, a double layer of collagen membrane to cover is always good, and then have a good closure of the flap. Come back in about 2 to 3 months of time, depending on what protocol you're following. Go ahead, give temporary, and then change it over to a permanent prosthesis. What you need to appreciate here is, though the buccal cortical plate was completely missing, and now you see a regenerated buccal cortical plate here, a very good regenerated buccal cortical plate, which is there in the canine region, because of the augmentation which is done. If you look at these cases here, the case looks very beautiful with 3-year follow-up. But what you have to see here is there is a defect which is there in this particular region. Why do you think this defect has happened? Though it's a success aesthetically, but if this patient had a high smile, I would have lost the same emergence in this particular area. So why there is a defect in this area? The defect is mainly because of not augmenting after immediate extraction, but by placing the implant thinking that there is no change in the contour which will happen. It's always best to do an augmentation in the anterior region. Though your implant might look good, there is a loss of soft tissue which is there. So as I told you in my first slide, it is not just the hard tissue or the osseointegration that we are looking at, but we are also looking at soft tissue integration, also having a good soft tissue profile to give a natural looking prosthesis. So you could go ahead and do a prosthesis which will look natural. What you also need to avoid or tell the patient to do is try and avoid flossing as far as possible. That is, using an intradental brush as far as possible. Because if you had to look at the papilla here, there is no papilla which is there. But because of the creep, gingival creep which is there, it fills up in that area, and then the papilla forms. So if the patient had to continue using intradental brush, this is very common, when you get the work, especially from dent care, which most of us, I think, give the work to, they always send this intradental brush along with the implant work. Please do not give it to the patient, but throw it in the dustbin, okay? Because you need to close these gaps by your processes and not by telling the patient to use the intradental brush and then try to have a recession in that particular region. Try to have a normal looking gap. Well, a lot of things have changed over years, and we have been looking for solutions, especially in the aesthetic zone. And one of the solutions which recently has become very popular is the socket shield technique. If you have to look into the socket shield technique, what is done is the tooth is extracted, leaving a thin wall of the buccal aspect of the shield. That is, you would prepare the shield of the teeth and just leave it there without extracting that particular area. Okay, so the shield is just left behind in this area. So you see the shield here, only a part of the shield is left behind and the tooth is extracted, and you place the teeth in a three-dimensionally perfect position, and then you could go ahead and then place the implant and then also load it at the same time. Well, you could go by the look into this article, the socket shield technique. It's recently published by Mark Huzeler. Okay, it's just published, I think, about a month or 2 months back. This article is published. It's a very nice article which will tell you the step-by-step protocol to follow with 12 years of their experience. That is published in the International Journal of Aesthetic Dentistry in the autumn issue. Okay, page number also is given here. So you could go ahead and look into that article. This would preserve the natural contour. So this is immediately loaded. So a composite restoration is done immediately by using a temporary abutment. And this is how the smile looks like. Of course, the length of the teeth is slightly smaller than the adjacent teeth, because I would not like to have any contacts in centric or in protrusive movements when during the healing period. Then we come back and then do a hybrid abutment, that is, use a titanium base and then make a zirconia core on top of it. And then for aesthetic reasons, you will have a nice hybrid abutment and then a lithium disilicate crown, which will give excellent aesthetics. And also the profile is maintained, the same profile is maintained as the adjacent natural teeth. So this is something what you could look at in future as one of the options, though, it's done by a particular group of people as of now, mostly by Mark Huzeler and Otto Zur. These are the two guys who are majorly into the socket shield technique. But yes, of course, you could go ahead and do this technique, provided you do it the right way. I'd like to show you another case of premolar. Also, when you do an extraction and immediate placement in the premolar region, what we always end up is a big the socket is quite big, and then there is a big jumping distance which is there. So we need to augment. So how much do we augment? Always place a gingival former at the same time. Okay, always place a gingival former at the same time. Don't go in just with cover screw, and augment up to the head of the gingival former. Don't just if you have to place a cover screw and augment on top of the implant, by the time you come back after 3 to 4 months of time, you will always see the buccal aspect of the implant being exposed. This is always what you would have seen. So to avoid that, always put the gingival former, a short head gingival former, that is might be a 2 millimeter height gingival former, or depending on what you're using. I usually like to submerge my implant by about 1.5 to 2 millimeter. So I would use a 4 millimeter height gingival former instead of a 2 millimeter height, because I like to submerge my implant, because I would like to always use a platform switched implant with the conical connection, and this works well, especially for an immediate extraction placements. And also, since I'm submerging by 2 millimeters, I would like to have a gingival former with additional height of 2, which is about 4 millimeters. So, and then augment up to the head of the gingival former This is how it looks on the X-ray, and then close the flap. Come back after, if you have to look at this gingival former, this is a bottleneck gingival former. So these kind of gingival formers is what you need to use, or you could customize the healing abutment by making it a bottleneck. You get bottleneck gingival formers, or you could customize the healing abutment. You get the polymer-based healing abutments which are there, which you could customize and make it a bottleneck, or if it's a molar region, you could add some composite around it and then get the same contour of the molar during the healing period itself. So this is what you could try and do, because the bottleneck gingival former will help you in having more amount of soft tissue here. And when I make my prosthesis, I would have a good emergence profile, which is there. Though it's a premolar, you would see a good emergence of the natural emergence, which is there with the premolar region. So you need to augment in the areas where the bone, where the bone is deficient. Coming back, or to summarize, what we need to look at is, as a clinician, I would always tell, gain experience and improve your skills. Improve your skills by attending a lot of workshops. That is what I keep doing always. Every year I would like to attend at least 1 or 2 workshops to improve my skill. And also your clinical judgment is quite important at the time of implant placement. A person with a good judgment will always know how to manage a complicated situation. So you need to have a good judgment at the time of implant placement. If you're going wrong somewhere, you need to judge that you're going wrong, and then you also need to manage it well. Well, of course, documentation is quite important of your cases, though documentation of all the cases would be very good. At least some of the cases would be very good, because documentation would help in understanding what you're done. And also, when you look at the documented cases, especially your clinical photographs, when you look at it, you come to know where you're gone wrong. Okay, you learn from your own mistakes most of the time, and then you don't do it again. Okay, of course, when you do an augmentation procedure, we need to understand the dental risk and the medical risk which are involved, and also the risk of smoking more than 10 cigarettes a day. I would not place the implants for these patients. Okay, I would tell them to quit smoking and then come back, and then I would place the implants for these patients. It's better not to place an implant in patients who smoke more than 10 cigarettes, because there is a high chance of implant failure. And also chronic alcoholic patients, also you need to try and avoid placement of implants. You could always manage with the SSA classification tool. Always use the SSA classification tool. It's free for everyone. So you could go into the ITI website, iti.org. There is a tool which is the SSA tool. So you could go and click on the SSA tool, and then all the modifiers come in. If somebody wants to show it, I can show it in the end. If you're interested, I can show it how to use the SSA tool. Of course, the biomaterials, you need to try and use a good biomaterial. Please do not use a biomaterial which is not documented enough. There needs to be a good supporting documentation for the biomaterials that you use, because you're going to use it on the patient. So whenever you use it on a patient, use a biomaterial which has got good long-term documentation, and not use just a biomaterial which is just because it's cheap. I don't believe in using a biomaterial, because at the end of the day, you're trying to treat the patients here. We're not trying to look at cost management, but cost management, of course, is an important factor. So you need to tell this when you're practicing to the patient, okay, this is going to be the cost if I'm going to augment. But if I don't augment, you're at a risk of losing the implant. So, what is it that you want? After spending so much, would you like to lose an implant? So definitely the patient would agree for augmentation procedure. So use a good augmentation material. A xenograft material is what I like to do for contour augmentation, along with the chips of autogenous grafts. If it's a large augmentation, then I would, especially in a single wall defect, then I would use a mix of xenograft and autograft in a proportion of 50% each. Okay, that is, mix them and then go ahead and then place in the graft, because I need to regenerate the bone at the same time, prevent the resorption of the bone. So I would like to mix this. But as just for contour augmentation, I would put the bone chips on the surface of the implant, and then the rest on contour. For contour maintenance, I would do it with the xenograft material. You could use a combination of xenograft and allograft, which I've recently started doing. not much of a documentation is there in support for this, but yes, that is because these are two different schools of thoughts which are there. But yes, it does work well according to my experience. It does work well, but you need to investigate on your own about this particular way of going ahead and doing the augmentation procedure. Thank you all for your attention. I would like to thank again Karnataka Prosthodontic Society for giving me an opportunity to share my experience and whatever I know about. And also would like to thank the NITE University for providing the platform on which I could present. My teacher, especially Dr. N. Sridhar Shetty sir, and the rest of my teachers who have taught me and always supported me at all times whenever I required. The panelists for the day also I would like to thank Dr. Chetan Hegde sir, Manoj sir, Shashidhar sir, Sanat sir, and Sunil Dede. Everyone I would like to thank. Thank you one and all. If there are any questions that I could take in, I'd be more than happy to take. Thank you.
Thank you, Dr. Rakshit. Actually, there is a question from...
I can't hear, sir.
Should I take that question?
Sir, I can't hear.
Hello.
Shashi, do you want to take the question? Please unmute yourself.
The question is, good morning, sir. Should a healing abutment always be placed at the time of implant insertion, even if we are not placing immediate implants? And when, how would we not place it with the implant?
Okay. If healing abutment, I would say healing abutment is best to be placed at the time of implant placement because you're going to avoid a second stage surgery. So the protocol to follow, I would say, is when you have good enough primary stability, something like in the range of a minimum primary stability of about 20 to 25 newtons is also enough for you to place the healing abutment at the time of implant placement, if in a regular case also, because this would not just help you in avoiding the second stage surgery, but also would help in having a mature soft tissue at the time of prosthetic phase. So, the soft tissue also needs to be stabilized, and the soft tissue to get stabilized in that particular height would take about 4 to 6 weeks of time. So, even if you're doing something like an early loading at 6 weeks of time, the soft tissue has very well stabilized at that particular 6 weeks of time. So, we need to try and understand this and then go. I would always like to put my gingival form or healing abutment at the time of implant placement, not just for immediate extraction placement, but also for delayed placement protocols. Yeah. Was I clear enough?
Yeah, that's fine.
Yeah.
That's all right. There's one more question on the YouTube platform.
Chetubhai, you are not audible.
Hello.
Chetubhai.
Am I audible?
Chetan sir, better, but it's not very clear.
Just a minute. Is it okay? Is it any better?
Hello. Hello.
Better, sir.
Hello.
Can you hear me?
Yes, sir.
I'm Dr. Sridhar Shetty.
So good morning, sir.
Yeah. So it was a very nice presentation, Dr. Rakshit, and
Thank you, sir.
I also learned many things from you now. I would like to, I would have been very happy if you have shown some excellent cases where you have lost all the maxillary region bone, or a patient who have been undergone some surgery, major surgery. How would you, in fact, at your level, such presentation would have been a much better for people who are already in a practitioners, practitioners in our prosthodontic society.
Yes,
So
sir.
anyhow, your lecture was excellent. I think, yeah.
Yes. I thought, I wanted to make some concepts very clear, sir. So, I didn't go on showing the cases. So I thought, I wanted people to know the concept of augmentation, when to augment and how much to augment. So this is what I was trying to focus on, sir. So that's why I didn't concentrate more on cases, but I concentrated more on about the concept of augmentation, sir. But I could always show it in the next presentation, sir, maybe.
No, you should do one more presentation with complex cases.
Yes, sir. Yes, sir.
No, I think Secretary Sunil will help you in organizing this, and you should continue. You should continue this implant programs, the lectures for the full year. It should be from your. It can be from Manoj. It can be from Chetan, or even if Sanat is also, I think, he is very much interested. So you should make a series of implant programs from to the beginners to the professionals who are already practicing. So I think we make a most important aspect in our restorative dentistry today is that if nobody knows how to restore a lost tooth in by placing an implant, and this is the most recent method of restoring the lost teeth. So I think we should educate all prosthodontists that their first attempt is not only an implant placement if patient can afford, but if they cannot afford, what would be the other treatments? There are many ways of replacing the teeth. But we should know that people should know that today it is possible to give a most permanent restoration for the lifetime. So I think you should educate our prosthodontic society people that in spite of doing all other work, the implant supported processes is the one which should be in the field of prosthodontics. It should not be in the field of somebody else. So you should be a more prosthodontist should be doing a practice on implantology. So I think your series of lectures, what you are going to do, should impress upon all prosthodontists that they are the real restorative professionals in doing an implant dentistry. It's not like, I can do an extraction of a teeth as a prosthodontist. I've learned that. I can do an impaction also. But I don't do it because it's a field of an oral surgeon. But implant placement and restoration is only by prosthodontist. This should be made very clear to all this. Though we have to have an influence of a periodontist or an oral surgeon in these aspects. But everybody can do an implantology. But what prosthodontist can do as a prosthodontist in restorative dentistry has to be focused in this series of implant dentistry. So I would say, congratulations, Rakshit, your lecture was excellent. And it's very educative, even for people like me who learned many things from your approach. It's a very exhaustive lecture, well referred, well presented. Congratulations, keep it up.
Thank you, sir. Yeah, I see another question here from Rohini Radhakrishnan about, she asked me about thin bone phenotype, soft tissue compensates. Okay, she's asking me, does it affect osseointegration? That is, when a thin phenotype kind of a situation, is being converted to a thick phenotype by waiting for about 8 weeks, does it affect osseointegration? Well, Rohini, what we need to understand is that we are waiting for the natural healing process. So in this natural healing process, what's happening is the socket is being filled with the soft tissue which is there, and then when you put the incision, you have to put the incision on the palatal wall, and you're going to reflect the entire soft tissue. There's not going to be any epithelium left inside the soft tissue, inside the socket region. And then you're going to place the implant in the socket with an augmentation material also covering on top of it, and a collagen membrane which goes on top of it, and the soft tissue which is there is just going to change the biotype from a thin biotype to a thick biotype. It's not going to affect the osseointegration ever. You could go with the, go by the article of Vivian Chaplus. Vivian Chaplus has written a beautiful article on how this thin biotype can be converted to a thick biotype. In fact, Bonstein's article also tells you about how the thin biotype is converted to a thick biotype by waiting for about 8 weeks of time. Another question, what I see here is of Gauss about pink and white. Yes, about anodized titanium implants, pink and yellow color, are better than hybrid implants in terms of pink aesthetics. Well, aesthetics, when it comes to aesthetics, what we need to understand is that the placement of the implant is the key here. The displacement of the implant in three-dimensionally perfect position will give you excellent aesthetics. Whether you're using bone level implant or a tissue level implant. In fact, I'm going to discuss something in the weekend to come, something to do with the tissue level implant in the aesthetic zone, which is at the Mangalore Study Club. In that, what happens is there is absolutely no difference between a bone level and a tissue level implant. It all depends on how you place the implant in a three-dimensionally perfect position. So if you place the implant in a three-dimensionally perfect position, it really does not matter about the pink and the white aesthetics, or we're using a hybrid implant, wherein you have a collar, which is there, which is polished, which is about 8 or 3 meters. In the anterior region, if you're using a hybrid implant, you need to use something like a 1.8 millimeter collar, because we are looking at having the rough surface of the implant 3 millimeter away from the future zenith of the restorative margin. So when it's about 3 millimeter away from the future zenith of the restorative margin, you have about 1 millimeter hiding inside. That is inside the final restoration. So you could use any kind of implant provided you put the implant in the right position. If you have whatever, even if you use a zirconia implant, which is the best implant to use in the aesthetic zone, you would still end up with aesthetic failure if you place the implant buccally. So placing the implant in the right position is a good way to go ahead. Kaiser Syed, I see his question here. Implant body design, what should we use in the anterior region? I would say narrow implant is the best to use in the anterior region. Don't go with very wide implants, because the moment you start using wide implant, you lost a lot of bone. Okay, and especially if you have to augment, please do see to it that there is about at least about 1.5 millimeters of augmentation materials on the buccal aspect of the implant, which is still within the contour. You can't graft outside the contour of the buccal aspect and expect the bone to form. You can't place an implant outside the contour and expect bone to form, even if you use the best graft material, because the muscles are going to keep compressing on the buccal aspect, and then there is going to be bone resorption taking place. So don't place your implant outside the contour, but place it within the contour. So whichever is the company of implant that you're trying to place, I would always say go in with a platform switched implant in the anterior region, because when you go in with a platform switched implant and a bone level platform switched implant, the complications are comparatively less when compared to a tissue level implant in the anterior region, though you could always use a tissue level implant in the anterior region also. Yeah, I think I've answered most of the questions what I saw here.
Yes, Rakshit, most of them are covered up.
Hello.
Yes, sir.
Hello. Can you hear me?
Yes, sir.
There's a question on YouTube. There is, in case, sorry, just a minute.
Sir, it is not audible.
In case?
Yeah, what about flap approximation with gingival former?
In case we are doing the grafting, sir?
Yes. When you're using a
Okay.
gingival former.
What about the flap approximation? Okay. What we need to do is, if I had to go with the presentation here, I'll just go up and just show you. Okay, if you look at this is with the cover screw. But if I had to use a gingival, if I had to do a flap approximation, what has to be done is you need to use a blade. Okay. What you could do is you use the BP blade and relieve the periosteum. Relieve the periosteum and then move the flap downwards. Okay. Incisally move the flap down. It should be in such a way that without tension, you should be able to flap. Okay, so what you need to do is you need to relieve the periosteum which is there. So you could use the back end of the blade. Okay, don't use the cutting surface of the blade because there is a chance you can cut the tissue so much that you might perforate the entire flap. So you need to use it in a brushing action on the back end of the blade where it's hardly cutting. You could use it in that fashion, and then you could relieve the periosteum, and then you could get a good closure. So what you're trying to use is a 2 millimeter height gingival former most of the time, where the additional height of might be about 1 millimeter, which will be there for soft tissue coverage, which is there usually with most gingival formers. So in such a situation, you're going to augment plus cover the flap and then close it on top of the gingival former. What we also need to understand here is those gingival formers should not be reused. That means, you need to use a new gingival former whenever you're doing this procedure. Ideally speaking, no gingival formers need to be reused because there is a formation of biofilm on top of the gingival former whenever you put this gingival former in the patient's mouth. When the gingival former is exposed to the mouth, there is biofilm formation, and this biofilm is formed for the next 1.5 to 2 months of time, and then you're trying to take it out. You're trying to, what we usually do is we ultrasonically clean it and then autoclave it and then try to use it in the next patient. Okay. Is this ideal to do? I would say no. You're trying to contaminate the implant by doing this, because what is happening is though there is no infection, which is cross infection, which is there, if you look at the soft tissue which is formed around the implant, wherein you reuse the gingival former, the soft tissue is not as healthy as it is when you use the gingival former for the first time. So you could compare between these two, and then what you usually see is the soft tissue is not as healthy as it would have been when you use the first time. So always use the gingival former only once, and especially in cases where you're trying to submerge the gingival former, these gingival formers need to be used for the first time itself. Please do not use a reused gingival former in these conditions and then try to augment, because you already have a biofilm on top of it, and then you can have anaerobic infection, especially in the area where the hex is coming. So see to it that there is proper coverage of the flap when you're closed after doing this kind of a procedure. So please follow this kind of a procedure if you're doing an immediate placement with augmentation at the same time in these kind of clinical scenarios.
Thank you, Rakshit.
Yes, sir.
Hello?
Yes, sir. Can hear, sir.
All the participants will get a feedback form. Please do fill in and send it in order to get your certificate of participation. One more question, I guess. If you would like to take it.
Yeah, from Swapnil. Yeah. does the type of processes make a difference in implant placement, loading, in maintaining the emergence profile, a cement or a screw retain? Okay, it's best to go in with the screw retain processes if you're trying to do an immediate load. And also the emergence, let me tell you, don't keep the same emergence what you're planning for the final processes. Keep the emergence slightly less, especially at the cervical aspect, because when you keep the emergence slightly less at the cervical aspect than the future emergence, you have soft tissue rolling downwards. And also, I showed about the bottleneck gingival former. So try to create that bottleneck below the mucosal region. So, when you try to create the bottleneck below the mucosal region, which is there in the temporary that you made, you have more amount of soft tissue which is there in that area. And then when you change it over to permanent processes, then you go back to the same emergence, or you wait for about 6 weeks of time and then remodify your temporary to the actual emergence, and then make your final impressions by using the index of this emergence what you had for the temporary processes. So this is how you need to go ahead and then do the immediate loading. So during immediate loading, keep the emergence slightly less. Don't keep the same emergence of the natural teeth, because when you keep the same emergence of the natural teeth, you have a slight recession which will take place in that area.
There's one more, Rakshit.
Yeah, gingival former needs to be covered completely. Yes, especially if you're doing a contour augmentation, it's best to cover the gingival former completely. Yes. So, you could keep it open if it's something like a 4 millimeter height gingival former, what I used in one of the cases, then, part of the gingival former can be kept open. But, I would always like to close my gingival former, because I would like to put my collagen membrane on top of the gingival former also along with the graft, and then close it down completely. So, I have more amount of regeneration taking place, because I can always push the mucosa apically, but never be able to regenerate the mucosa incisally. So this is what we need to try and understand. Anything else, sir?
I don't think no more questions.
Okay.
I think we just have a few comments. Excellent presentation, very informative, and definitely it was a super presentation, Rakshit. Thank you very much.
Thank you, Sunil, for giving me the opportunity.
Dr. Rakshit, it was a very good presentation.
Thank you, sir.
Yeah.
Thank you, Dr. Rakshit.
Thank you, sir.
I would like to invite Dr. Gandraj Shetty to deliver the vote of thanks.
Good afternoon, everyone. It was an excellent presentation by Professor Dr. Rakshit Hegde. On behalf of Department of Prosthodontics and Implantology, A.B. Shetty Memorial Institute of Dental Sciences, I would like to thank Indian Prosthodontic Society, Karnataka State Branch, for giving us an opportunity to host today's webinar. I would like to thank President, Indian Prosthodontic Society, Karnataka State Branch, Dr. Sanat Kumar Shetty. I would like to thank the President, Indian Prosthodontic Society, Karnataka State Branch, Dr. Sanat Kumar Shetty, and the Honorary Secretary, Indian Prosthodontic Society, Dr. Sunil Dadet sir, for joining us today. I would like to thank Dr. H. Shashidhara sir and Professor Dr. Chetan Hegde sir for moderating today's webinar. I would like to thank the past president, Professor Dr. Manoj Shetty, for joining us today. And I would also like to thank the senior most prosthodontist, Professor Dr. N. Sridhar Shetty sir, for joining us today. It is an overwhelming response to see all the members of Indian Prosthodontic Society and Karnataka State Branch, the postgraduate students, and the faculties from other society, other specialities joining us today. for taking out your time from busy schedule. Last but not the least, I would like to thank Professor Dr. Rakshit Hegde for consenting and delivering the wonderful lecture. Thanking you for your gracious presence. Thank you one and all. Thank you. Have a nice day.
Thank you, Ganraj. Thank you, sir. Thank you, everyone.
Yeah, before we end, I personally like to thank Dr. Manoj Shetty, who was the coordinator for this program, and because of him, this program has been successfully carried out today. Thank you, Dr. Manoj Shetty, very much.
Thank you.
Yeah, thank you.
Thank you, Rakshit. Bye.
Thank you.
Chitu,
Thank
bye.
you, everyone.
All, thank you. Bye.
Thank you, sir.
Yeah.
Thank you, Jason, sir.